DOACs should be considered as a standard of care for the treatment of patients with cancer-associated thrombosis, CAT, except in the patients with a high risk of bleeding. DOACs, as a class of drugs, significantly lower venous thromboembolism recurrence without a significant increase in the risk of major bleeding. Amongst the DOACs, although apixaban shows the most favorable bleeding profile, but it is really hard to choose the clear winner with the currently available evidence. My name is Irbaz bin Riaz. I'm Assistant Professor of Medicine in Hematology Oncology Department at Mayo Clinic in Arizona. I will be talking about the manuscript, Direct Oral Anticoagulants Compared to Dalteparin for the Treatment of Cancer-Associated Thrombosis, a living, interactive, systematic review and network meta-analysis, which will be published in the February 2022 issue of Mayo Clinic Proceedings. We have developed a novel approach to creating living systematic reviews and meta-analysis. We show using our approach that we can update the evidence as soon as it becomes available. We use a framework of advanced programming and AI to do that. These results are available on an interactive website that patients and clinicians can use for shared decision making. In this analysis, we combine the data from all 4 major clinical trials, Hokusai VTE, SELECT-D, ADAM VTE, and Caravaggio, which compared DOACs versus Dalteparin. The results show that DOACs as a class of drug significantly lower the risk of VTE recurrence in cancer patients as compared to Dalteparin. There's a significant odds ratio with this analysis of 0.59. In terms of absolute numbers, patients treated with DOACs in clinical trial settings had 35 fewer events per 1,000 patients treated with DOACs as compared to Dalteparin. In terms of bleeding, although DOACs increase the risk of clinically relevant non-major bleeding with an odds ratio of 1.65, but more importantly, there was no significant increase in the risk of major bleeding with DOACs as compared to Dalteparin. Numerically, more GI and GU bleeds were seen in the patients treated with DOACs, but we remain uncertain about significance due to small number of events. Some comparisons hinted that apixaban may have most favorable bleeding profile, especially in comparison to Dalteparin. There was no increase in major bleeding or clinically relevant non-major bleeding as compared to Dalteparin. However, there were no significant differences amongst DOACs, either in major bleeding or the VTE recurrence. Limited drug and food interactions, predictable pharmacokinetics and pharmacodynamics, rapid onset and offset of action, short half-life, and lack of the need for lab monitoring makes DOACs very appealing both for patients and prescribers. This analysis, using totality of randomized evidence, show that the DOACs are safe and effective and hence should be standard of care for most patients. Numerically higher number of GI and GU bleeding in DOAC group certainly merits caution with the use of these agents in these high-risk patients. I don't think we have a clear answer if a particular DOAC is a winner. Apixaban had fewer bleeding events, but it is hard to be conclusive about it given a small number of trials and the sparsity of data. The choice of DOACs at this stage may be determined by the patient and physician preference, access to drugs, type of insurance, etc. These findings mean more formal access for patients to these drugs, especially as apixaban will be included in clinical guidelines. Real-world studies suggest that DOACs were already a popular choice even prior to the publication of latest trials like Caravaggio. With this data, patients and clinicians can be fairly comfortable with the use of DOACs in clinical practice. We host all this data on a living interactive website, which means that clinicians and patients can look at our website, interact with these results, visualize the evidence from different drugs, and see how they compare with each other. We update the data in almost real time so that most updated data is available for clinical decision making. In conclusion, the strength of this manuscript lies in the platform methodology, which allows for inclusion of the new data as it becomes available. As the new data becomes available, website will be updated such that entirety of the data will be included in the analysis. Therefore, I invite you to read this manuscript with a particular emphasis on our approach to living evidence synthesis and future iterations of this analysis.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.